Welcome, everyone. Thanks for being here. I'm Mariangela Pellegrini. I'm the Educational and Patient Manager for the ERN-EuroBloodNet, and I have the pleasure to welcome all of you to the 10th session of the topic on focus on Willebrand disease for patients, organization, and healthcare professional that has been coordinated by the ERN-EuroBloodNet and also the patients organization European Haemophilia Consortium that is represented by the EHC Willebrand Disease Committee, also via our ePAG, Baiba Ziemele. And so this educational program indeed is a joint project because it has been created in partnership with EURORDIS-Rare Diseases Europe, and also it has been supported by member of the scientific committee. So Professor Sophie Susen from the CHU in Lille in France, Professor Jeroen Eikenboom from Leiden University Medical Center in Netherlands, and Professor Flora Peyvandi from Ospedale Maggiore Policlinico Milan in Italy. So I pass the floor to my colleague Daria for introducing you the EHC committee and organization. Thanks, Daria.
Mariangela, and as per usual, I will start with some thanks because it is a truly unique project, and we are very thankful to the ERN-EuroBloodNet for this amazing opportunity to bring together clinicians, healthcare professionals at large, patients to discuss the most topical questions related to this bleeding disorder, which is von Willebrand disease. And my name is Daria Camilli. I'm Education and Communication Manager at the European Haemophilia Consortium. And EHC is an international non-profit organization. We represent 47 national patient organizations for people with rare bleeding disorders from 27 member states of the European Union and most members of the Council of Europe. In total, we represent approximately 120,000 people diagnosed with rare bleeding conditions such as hemophilia, von Willebrand disease, and other extremely rare bleeding disorders across Europe. Among those, von Willebrand disease is the most common bleeding disorder, affecting up to 1% of the general population. However, it is still often neglected and overshadowed by hemophilia. And with this program, we aim to distinguish von Willebrand disease from hemophilia, and we focus on the particularities of this bleeding disorder. In the framework of this program, we discuss very topical areas related to VWD among patients and healthcare professionals, and we give visibility to the challenges of those living with this rare disease in everyday life, including quality of life, access to treatment and care, medical services available in Europe, diagnosis, treatment options, and the overall patient journey through life. And this is our 10th session, as Mariangela already mentioned. So we had already 9 before this one, and we will have a few others. And today we focus on aging with von Willebrand disease, something that is not really widely discussed, and something that we really wanted to include in this program and to give very big visibility to this topic. And before we go to the introduction of the speakers, I pass the floor back to Mariangela to share with you some housekeeping rules and some very important information for the medical students that might be attending this webinar.
Thank you so much, Daria. Indeed. So this webinar has been accredited by the European Body of Accreditation in Hematology. So each session consists of an awarding of one continuing medical education point for receiving those accreditation or disaccreditation if you participate to only one session. You just need to participate to the webinar, and then at the end of the webinar, you are going to receive a satisfaction survey. So please answer it. This is mandatory for receiving credits. And when the overall program will be finished, so in 3 months, we will contact you and explaining to you how many credits you are entitled to receive, explaining, as I was saying, how to enter in the platform for submitting the credit. So don't worry, you just need to write properly your name in the Zoom and use the same email for the survey and for the registration of the program, and that's it, and we will contact you. Said so, as you are going to see, as you have may notice, this webinar is registered, and this is because the videos will nourish both the EHC and the ERN-EuroBloodNet e-learning environment. So the videos, the recording of the webinar will be available publicly. So if you don't feel comfortable, please notify to me or switch off your camera, so we will take care of it. And your microphone will be muted along all the presentation, but you have both options. You can write your comments, feedback, questions in the chat during the presentation, because at the end we will have a Q&A where your question, comment could be addressed. I was mentioning both options. So the second option is also that at the end of the presentation, you can raise your hand and we will give you the floor for unmuting yourself and raise your question orally if you prefer. Well, let's arrive now at today's lecture, as said, on aging. As usually, on this program, we count on multiple and multidisciplinary expertise for really tackling the topic in a broad sense, in a holistic way. So today with us, we will have a patient representative, a specialist nurse, and a nematologist. So I'm glad to introduce Professor Giancarlo Castaman, who is Medical Director of Center for Bleeding Disorder and Coagulation at Careggi University Hospital in Florence, in Italy, and is also the president of the Italian Society of Thrombosis and Haemostasis. Daria, do you want to introduce the other speakers?
Absolutely, with great pleasure. And I want to introduce to you Kathy Harrison, who has worked in the Sheffield Haemophilia and Thrombosis Center since 2006. Kathy is an adult nurse with a keen interest in the science of hemostasis. She enjoys her clinic role, and she also teaches both locally and on the contemporary care course for people with bleeding disorders. And on top of this, she's the chair of the World Federation of Haemophilia Nurses Committee. And I also want to introduce to you, with great pleasure, Nicolas Giraud. He's a patient himself, very well-known patient advocate and ex-president of the French Haemophilia Society. Nicolas, the floor is yours.
Yes, thank you very much, Daya, for this very kind introduction. I hope you hear me well, you see me well. So yes, like Daria said, I'm Nicolas. I'm French patient, and I've been an advocate for people living with Willebrand disease for over 10, 15 years at the French level, but also at the international level, EHC or the WFH, the World Federation of Haemophilia. And aging, it's a great topic because yes, it's true. Willebrand disease is one of the most common bleeding disorder, but it's one of the less, I would say, I don't know if it's less care, but at least less known in the medical circle, how to maintain, to take care of, to care, and also with less, I would say, access to therapeutics innovation. So that's also another thing I think that Willebrand disease or patients are deprived right now as far as innovation, therapeutics innovation. And aging for patients living with Willebrand, it could be a challenge, as we know that Willebrand disease is concerned, affect equally both men and women, and with different challenges on both sides. But also aging, that means that we are exposed to other type of disease comorbidities, like we would say health professionals. And that for some patients who are not so, I would say, affected or feel like, the von Willebrand disease is an issue because of the type, because of the expression, because every person expresses the disease differently, might encounter some difficulties when they're aging. And I think that's one thing that I would like to maybe underscore tonight, is how to connect or reconnect patients and health professionals to go along the path of aging and take care of different comorbidities, or like simple routine exam routines like coloscopy or any other things like dental cares, when they have never been exposed to a serious bleed or a serious chirurgical intervention in the past, who not really have the knowledge of the path where to reach out the specialist to be referred to with a specific protocol for the intervention and so forth. And I think that's, of course, there's other things that I'm sure would be presented by the health professionals tonight for that von Willebrand disease patients would be affected. But I think that's one of the major challenge that I would see, because it's true, the most severe patients, they have a certain knowledge about how to do it, how to handle a bleed, how to anticipate, how to reach out to health professionals. But those who are a bit less exposed to bleeds and have less experience with the health professionals and how to present himself or herself to health professionals in a routine, I would say, appointment, and explain and talk about his condition with von Willebrand, that would be something, I think, something as a challenge. And I think that's where we, maybe something that's to have to think, to underline, how to connect or reconnect the patients and the health professionals to go along the way of the path of aging. So I think as far as my introduction, Daria, I'm done.
So much. Yes.
So if you want to pass on to the next speaker, no problem.
We are passing the floor to Kathy Harrison.
Thank you very much. I'm just going to share my slides. Hopefully you can now see them.
Yes, perfect.
Fantastic. So first of all, thank you to the committee for the invitation to speak today on the subject that I'm very passionate about and what I've done quite a lot of work on, particularly in relation to aging for the person living with a bleeding disorder. This obviously focuses particularly on von Willebrand disease. Those are my conflicts of interest, perhaps more just disclosures. What I hope to do today is to discuss and highlight the role of the specialist nurse and where they sit within the MDT for the person living with von Willebrand disease, identify the most common presenting bleeding symptoms, discuss how we can manage the most common issues, and explore a little bit around health promotion strategies for those aging with von Willebrand disease. So to start with, why do we have comprehensive care? So what we're aiming to do with comprehensive care is to provide as much as possible on one site. So bringing everybody together to work collaboratively to support the individual and the family affected by the underlying bleeding disorder, to prevent ongoing harm coming to them, to support them to live independently, and to the best of their capacity. And this is not a new model of care. This has been ongoing for many decades, and we're increasing that and evolving that as we see that increase in aging individuals with bleeding disorders. So I think if we reflect back, we have expanded our teams. We have more social workers, we have more other teams looking at people like occupational therapists involved in their care provision. So we are thinking a little bit broader than perhaps we did 20 years ago, for instance. So where does the nurse specialist fit in this? So you might wonder why I'm showing you an octopus. A couple of years ago, I saw a presentation that reflected that the clinical nurse specialist was very much like an octopus. And you might think, yeah, 8 limbs, they're very good at multitasking, but it's more than that. We think about the octopus as within their order, 300 species absolutely reflects the number of different specialities that specialist nurses working. They have soft bodies that allow them to radically change their shape, reflective of the adaptive nature of the clinical nurse specialist role. And they have complex nervous systems with excellent sight and are among the most intelligent and behaviourally diverse of all invertebrates. They're recognised as problem-solving experts and with both excellent short and long-term memory, and they practice observational learning. So I think we can reflect that. Those of you who work with specialist nurses, you'll recognise some of those characteristics. Those who perhaps have worked in services for a number of years will be able to absolutely link generations of family together and remember what happened to an individual and that impact that will have on somebody's decision making throughout their lives. So those are absolutely key skills for being that holistic person to support and guide affected individuals through this journey. And that's not something that is new information. Specialist nurses are consistently rated higher than any other health and social care professional. They understand patient needs, they can design and implement new care pathways, and they can support affected individuals to make decisions through transparency and honesty. They are absolutely that first point of contact. They are providing triage skills to screen and assess individuals who are affected by specific conditions. They are offering up consultation appointments. They are providing health promotion through education to both patients and families, but also to other healthcare professionals. As we said, innovative practice, delivering cost-effective, high-quality care, which really seeks to link and support and work with the patient to ensure that they have the best possible outcomes. So we start with that first line of contact. So in many services, your clinical nurse specialist is your first point of contact. And even before COVID, when we moved, solely pretty much onto telephone, 40% of our activity was performed on the telephone. So supporting individuals, triaging, having conversations about symptoms, seeing if we need to bring people in, and coordinating care provision and supporting that navigation around healthcare systems. So if we reflect back on our own practice, just as a sort of a quick discussion with my colleagues, the 3 things that we see most of through that triage pathway are epistaxis and nosebleeds, heavy menstrual bleeding, including relating to the perimenopausal episode in life, and gastrointestinal bleeding. And that's supported by evidence, a recently published paper in the last year, evaluating the impact of living with von Willebrand's disease for individuals. So we recognise that increased bleeding impacts on life so fully. So it reduces quality of life, it reduces social function, it increases pain and reduces general health and capacity to be physically functional or active. So it's not just about that single symptom, it's about the whole broad spectrum of how it affects every aspect of life. So if we think about heavy menstrual bleeding, absolutely is one of the key reasons we get calls. So absolutely supporting and ensuring that we're monitoring for iron deficiency, and iron deficiency before anemia as well. So ensuring we're catching iron deficiency and treating it appropriately, ensuring that we're giving oral supplements in a way that is going to be tolerable, so either once a day or once every other day dosing, to prevent the side effect profile but improve outcomes. Utilising things like tranexamic acid to support people with heavy menstrual bleeding, particularly if they're not wanting to go down a path of hormonal therapies. But if we are looking at hormonal therapies, we can look at the oral contraceptive pill, and we can think about combined pill or progesterone only. And there are different aspects for why you might choose different therapies. The Mirena coil is particularly effective for managing heavy menstrual bleeding, but doesn't suit everybody, and that should be recognised. And if we've tried these approaches, we might need to take an approach of using things like DDAVP or indeed replacement clotting factor therapy if we're needing to completely correct the underlying bleeding disorder to manage that heavy menstrual bleeding. If we're thinking about treating with replacement factor or DDAVP, we may also be able to explore the use of non-steroidal anti-inflammatory drugs to help manage the pain related to heavy menstrual bleeding, but also help to reduce the heavy flow as well. It may be that we do have to explore surgical options, and in that case, and even in advance, having a joint consultation of a gynecologist and a haematology team together with the individual can see much more streamlined, better outcomes. We've really had very good feedback from the women that are included and have been seen through our joint clinic, where they can have that conversation about the benefits for each different approach, whether that be through hormonal therapies, surgical interventions, or merely by correcting their underlying bleeding disorder. So what about the perimenopausal state? If we're thinking about aging with von Willebrand's disease, we recognise that people who, women who are going through the perimenopausal state are more inclined to have abnormal uterine bleeding. It is common, but we should be exploring and ensuring that there isn't an underlying cause of this. And that can be that individuals are seen in a clinic. They can have a speculum examination to ensure there's no cervical or vaginal abnormalities. We can have a transvaginal ultrasound. It may be that individuals need to undergo things like an endometrial biopsy or hysteroscopy. And of course, that requires support from the bleeding disorders MDT to ensure that we can provide appropriate support to correct an underlying bleeding disorder along with that. Again, we can also see that we need to ensure that we're treating or monitoring for iron deficiency with or without anemia. And those same approaches can be utilised for managing bleeding during the perimenopausal state that we use earlier on in life. So how much evidence is there out there about going through the perimenopausal state and having von Willebrand's disease? Well, a big fat zero. So if anybody's wanting to do a PhD or a research project, this is absolutely bang on the note for needing some work. I've got an individual here, so a lady who just shy of 60 with type 1 von Willebrand's disease with BWF activity of 32 international units per deciliter, who also has Ehlers-Danlos syndrome. And she's been in contact with the service a number of times in the last 18 months to 2 years with recurrent, heavy and prolonged PV bleeding. She's attempted to use HRT to manage her perimenopausal symptoms. Unfortunately, when she was exposed to this, she had significant increase in her PV bleeding and had to stop the therapy. She's had investigations to rule out malignant causes. And unfortunately, in relation to her EDS, she has had side effects with progesterone. So she's really struggling to manage this bleeding that she's experiencing. We have discussed the Mirena coil with her previously, and she is coming back to a joint clinic in the future to discuss the possibility of a Mirena coil again. there is a risk of perforation with Ehlers-Danlos syndrome, and that this is one of the discussions why we need that broad conversation to think about all aspects of the affected individual. And that is why ensuring that individuals who are affected with such conditions are seen by experienced professionals, so that they can have this type of intervention by somebody who isn't going to cause further harm. We're currently using on-demand Peyvandi to manage her bleeding episodes, and offering her the option of coming in to learn how to self-inject herself as she lives some distance from the service. And she's using tranexamic acid, pretty much like Smarties during this episode. One of the other considerations is that she has GnRH analog injections to induce full menopause at this point. And certainly GnRH injections have been used for a number of our younger women to manage heavy menstrual bleeding, particularly type 3 von Willebrand's disease, where actually we've been really unable to control the bleeding in any other means, even with prophylaxis. What about the next most common bleeding presentation? So absolutely in von Willebrand's disease, it has to be gastrointestinal bleeding. And although we recognise that this presentation is more prevalent in those with von Willebrand's disease, it is absolutely not the underlying cause of the problem. So they should always be investigated. And that is something that it can sometimes be very difficult to translate to primary care, perhaps if people are calling and not realising that it's not a reason to bleed. We would always ask that individuals are investigated. And it's difficult sometimes to gauge how significant gastrointestinal bleeding can be. And that is why it's important that we bring individuals in, that we're performing bloods to check for full blood count and iron profiles, and that we're referring to appropriate services to perform investigations. One of the most challenging gastrointestinal bleeding causes is angiodysplasia, which we see as an increasing pattern in individuals who are aging, but we see a particularly problematic bleeding pattern in individuals with von Willebrand's disease and in some platelet function disorders. And Professor Castaman is going to cover that a little bit further in his slide deck. But just for instance, we've got a couple of cases here, a couple of type 2 ladies, both in their late 50s, one with type 2A and one with 2M von Willebrand's disease, but with very similar von Willebrand activity levels. And you can see they've got a very similar bleeding history as well. So both having heavy menstrual bleeding. One has had particularly significant oral bleeding and nosebleeds. One has particularly nosebleeds as being the most significant issue. And both have experienced in their middle life GI bleeding. So they've been investigated. One has been confirmed to have angiodysplasia. And those of you who've worked in the condition will recognise that we don't always find the sites where we feel that there is angiodysplasia present. You can see the sort of evolution of treatment that these women have undertaken. And we can see, as with many type 2 von Willebrand's disease, DDAVP not responsive, or certainly not adequate to normalise von Willebrand levels. And tranexamic acid is a staple of the armoury for supporting. But in both cases, we've reached a point where introducing prophylaxis with clotting factor concentrate has been needed. And we've taught both these women how to self-infuse later on in life, one for just a short period of time and now is back on demand, and another one who is using Voncento 25 units per kilo, usually once a week, sometimes twice a week, depending on what other activity is going on. But what I thought was really interesting was that she felt for a long time von Willebrand's disease didn't rule her life, that actually it didn't, although she's had this bleeding history, it didn't have a huge impact on her. Whereas once she started having GI bleeding, it absolutely ruled her life. And starting Voncento prophylaxis made her feel like life is calm again, that she was back in control, that she could work, that she could spend time with her family, that she could book trips. And I think that's really important to recognise. While we might feel it's a big hurdle learning to self-inject, the impact that it's had on her life is tremendous. The next most common, and I think increasing issue in our aging group, we particularly see it in perhaps in our adolescents, and then we see a peak in our older group as well, is nosebleeds. And you know, there are many reasons for nosebleeds, but as people age, nasal tissues dry out, they become thinner, and that increases the risk of bleeding. Additionally, we see uncontrolled high blood pressure also impacting on that. And if we think about the polypharmacy of the number of different medications that individuals might be on as they age, the addition of drugs such as aspirin or antiplatelet therapies because of comorbid cardiovascular disease could impact on the increased prevalence of these types of pictures. So the use of things like Naceptin, Vaseline to moisten linings, the use of tranexamic acid, and in some cases, the need to, again, learn about prophylaxis is important, but also having a really good relationship with our ENT teams about supporting appropriate interventions for people having this type of bleeding is significant. So if we reflect back on that conversation I'd had with the lady with von Willebrand disease who felt her life was calm, and think about what individuals who are in the public, what's that perception of what healthy aging looks like? So it's really broad piece of work from nearly 65,000 Twitter posts looking at what is healthy aging to the general population. It looks like being able to enjoy things like culture, so art and music, being able to socially interact, being able to eat well, be physically active. It means being able to have good cognitive function, looking healthy, having good gut health, being able to sleep. It means having vaccinations to prevent getting ill. It means not having trips and falls. So there's a number of considerations. It's not just about a one thing. It's a really broad spectrum of things that mean somebody feels healthy. And that's why health promotion is a huge part of our role within specialist services. It's not just about ensuring that individuals are healthy from the point of view of their bleeding disorder, but it's about ensuring that broad spectrum of health. So ensuring that they realise the impact of activity and exercise, ensuring that they attend cancer screening programmes, and that they realise that having a bleeding disorder is not an exclusion to attending this type of event, and that we can support and should support them to undergo these screening programs. Likewise with vaccinations, ensuring individuals have appropriate information. For instance, during COVID, when we provided a leaflet and information very quickly out to our patient group to ensure that they knew how and when they could access vaccination safely. Reflected back on Nicolas's statement about dental care, ensuring that they have appropriate access to dental care, that actually they, if they need extractions, that they're done safely with appropriate cover, that they can access appropriate dentures so they can still eat well. And it's really important that although we're the specialist services, we're not experts at everything. So ensuring that we coordinate and navigate that liaison with primary care to ensure that they have appropriate access and support for their well man screening, the well woman screening, that they have appropriate smears and mammograms, that they go and have their blood pressure and diabetes checked. And that's not to say that there isn't a role for us doing that as well, because there absolutely is, but we are not the experts, and we should be liaising very closely with our primary care colleagues. And this is absolutely one of the key roles of us as specialist nurses, is that we can support that navigation through healthcare systems, because it can be an incredibly rocky road and complex if you're having to navigate through multiple different teams in different hospitals and different systems. So having someone to support you through that process, ensuring everybody gets the appropriate information about the underlying condition and the appropriate treatment that is needed, is really part of a key role for us. So what are the take-home messages from a nurse's perspective? Evidence of care management in aging people with von Willebrand's disease is really limited, and we need to do more research and share our experiences. So it's not just about studies, but it's about registries, it's about us sharing our experiences, discussing cases. Bleeding presentations vary significantly, and they may improve as people age, but they also might deteriorate. And when they do deteriorate, it can add a heavy burden on the individual's overall quality of life. Access to timely diagnosis and provision of specialist services is key to that, ensuring they know how and when to access us, and listening to the overall impact of bleeding on the individual, and actually what are their goals in life in order to support them to do that. And it might be that we need to work with them to consider prophylaxis, but absolutely we need to be thinking about an overall individualized care plan to support that individual. So we're going to do questions and discussion at the end of the presentation, and I will hand over back to the team. Thank you.
Thank you very much, Kathy. So I will pass the floor to Professor Castaman, Giancarlo. Perfect. We can see your slide, but we cannot hear you.
Sorry,
No.
now you
Yeah,
can.
perfect. Thank you.
Sorry, it was me.
No, don't worry. Thank you.
Okay, first of all, thank you, of course, to the organizing committee for inviting me to discuss and to review with you what about, from the medical point of view, happens with the age in patients with von Willebrand disease, taking also into consideration that von Willebrand disease, as we will see, is a very heterogeneous disorder. So we will discuss how the different approaches and also clinical manifestation could impact on the quality of life of patients with von Willebrand disease undergoing aging process. So you see my disclosure. This is my agenda. Of course, we will try to discuss and to assess the risk of bleeding in the general population and in patients with von Willebrand disease. Then we will discuss what happens with von Willebrand factor during aging. What about the most critical bleeds, as already presented also by Katie, in elderly von Willebrand disease patients? And what about also the comorbidities? Because sometimes patients with von Willebrand disease may have significant and clinical overt cardiovascular manifestation that must be treated. So, of course, it could be a tricky situation. We try to see what to do in this situation. So what about the risk of bleeding in the general population of von Willebrand disease and overage? We know this is the data recently published on a large, very huge population of normal people, around 400,000 individuals. And the authors assessed what about the annual risk of significant bleeding in patients without taking any antiplatelet and of course anticoagulant treatment. And so you can see that there is a risk of 3% of median annualized incidence of bleeding males, and is very similar also in females over age. You see that the risk increase, especially after the age of 60. What about von Willebrand disease? Of course, the risk is even greater, because you see that approximately 6.5% of annualized bleeding rate is reported in patients with von Willebrand disease, starting from the age of 30. So these figures is steadily increasing over age, and there is no major difference apparently between males and females. But of course, we know that von Willebrand disease is a very heterogeneous disorder. The most frequent type is type 1, that is a partial quantitative deficiency of von Willebrand factor, while type 3, there's a most severe type of the disease is rare compared to the other patient. And then we have approximately 25% of patients carry mutation associated with a qualitative von Willebrand factor abnormality that, you know, according to the specific mutation, can result in 4 subtypes called 2A, 2B, 2M, and 2N. So according also to the specific mutation and the specific abnormality of the function of Willebrand, we can have very different clinical phenotypes. But in general, the disease is very heterogeneous, and we have a clinical evidence that the bleeding severity increases from type 1 to type 3, and treatment, of course, differs. And you can see that according to the WIN study in the Netherlands, you see that the bleeding score is definitely the highest in patients with type 3 compared to type 1, type 2. And even among the type 2 patients, you can see that there is different severity of the clinical phenotypes according to the classification. So this is, of course, important. This is a clue for having a correct and appropriate diagnosis to make an accurate prognostic view of the different risk of bleeding according to the type of von Willebrand disease. Well, if you consider and split the population according to, let's say, for example, in this slide, 16 to 64 years, and then over 65 years of age, you can see that there is some types of bleeding that may be more prevalent in elderly people. For example, as you already seen, GI bleeding is more prevalent in elder population compared to the younger, and also about the risk of surgery will be clearly a different issue compared to the younger people with von Willebrand disease. And this, if we consider significant bleeding, that is the bleeding requiring a DDAVP or replacement treatment with von Willebrand factor containing concentrate in the year preceding inclusion in the study for this population, you can see that hemarthrosis and GI bleeding are definitely more prevalent and more severe in elder people with von Willebrand disease. And here you can see again that if we assess the severity of bleeding with a standardized method, with a standardized tool that is the bleeding score assessment, you see that by increasing age, you will have different severity of bleeding in patients with von Willebrand disease compared to the normal population. So this is important to correctly diagnose patients with von Willebrand disease, to assign the appropriate type, and to follow according to the severity of clinical phenotype also during age. So to conclude this section, the incidence of bleeding symptoms is a 2 to 3-fold increase in the elderly in the general population. And when we have seen also that the same applies to von Willebrand disease patients, that probably in addition to the normal risk in the normal population, will have an additional risk of bleeding. So it could be really important, significant, and this disease, this patient population could be really estimated as a high-risk population. And also the importance of having a view of the type of von Willebrand disease to follow over age. You see how the bleeding score, that is the severity of bleeding phenotype, is definitely higher in patients with type 3 von Willebrand disease compared to type 1 von Willebrand disease, because the severity, the deficiency of factor A and von Willebrand factor is definitely worse in patients with type 3 compared to patients with type 1. Furthermore, we have also to consider the fact that in patients with type 1, and we will see later on, we will have a very large variability of von Willebrand factor deficiency, and so of course also the associated risk of bleeding could be completely different. So what about the pattern of von Willebrand factor changes and age. We know that in the general population, there is an increase of the von Willebrand factor A levels with age. And we know that since blood group is a major influencing factor on the von Willebrand factor level, we know that elderly AB subjects have a more pronounced increase compared to O carriers of the blood type O. So this is a clear associated to the fact that there is a higher glycosylation of von Willebrand factor in patients carrying the blood type NO. What about von Willebrand disease patients? You can see that for patients with significant decrease at the diagnosis, we will have no significant changes over the age compared to what happens in the general population. If we look also within the group of patients with von Willebrand disease, according to the presence of a mutation responsible for the phenotype, compared to patients without a mutation, and usually these patients have a mild deficiency of von Willebrand factor, you see that there is a significant difference over age. You see that there is no significant changes in patients carrying a specific mutation of von Willebrand factor responsible for von Willebrand disease. And you see that when patients have no detectable von Willebrand disease mutation, the pattern is not very different from what happens in the general population. And we know that for patients having mild deficiency, usually greater than the 30 units per deciliter, there is a significant increase over time. There is an age, clear and age-dependent effect. And sometimes if we have to check a patient for a first diagnosis, let's say, for example, at the age of 50, with mild bleeding tendency and von Willebrand factor level around 60 to 65, is very difficult to make a definitive diagnosis of von Willebrand disease. And sometimes we need to repeat the testing to avoid overdiagnosis in these situations. Here you can see summarize the pattern over a mean observation period of 11 years. And you can see that the same patient, the same individuals followed during this time. You can see that when they have a mild deficiency, they may have a significant increase over time. And this is particularly true for subjects with a partial deficiency. You can see that after 10 years of follow-up, there is a correction of the mild deficient factor levels at the baseline, while you can see that if the deficiency is a significant diagnosis, there is no major increase in the most significant proportion of patients. And as a matter of fact, patients with a partial deficiency associated with a type 1, that is quantitative deficiency of von Willebrand factor, in approximately 60% of patients, there is a normalization of the concentration, the activity of von Willebrand factor. But the most important information is the fact that the patient with the severe deficiency, usually less than 20 units per deciliter of factor A and von Willebrand factor, do not correct over age. So the risk of bleeding remains significantly high, and the need for treatment is definitely present compared to the other type of patients. And this has been suggested and partly proved to be associated with a combination that increases synthesis and secretion from endothelial cell, and also a reduced clearance of von Willebrand factor. So the half-life of von Willebrand factor seems to be more prolonged during age compared to the younger age. Here you can see again a recent study, and a study from Irish and Netherlands group combined, that subjects having a severe deficiency do not change over age. Partial deficiency may be corrected over age, and so this patient population are especially associated with complete desmopressin response with a decreased likelihood of finding a specific mutation and a less marked pathogenic defects. For patients belonging to group 2, you see that they have a persistent low level of von Willebrand factor. There is a very high likelihood to identify responsible mutation. Very likely these patients do not respond to desmopressin, and the mechanism underlying the disorder is especially associated with a marked biosynthesis or secretion and clearance defects. So this, of course, has been also tackled by the ISTH ASH guidelines recently published, because especially for patients with mild deficiency, sometimes we need to reevaluate the diagnosis of type 1 von Willebrand disease, since we know that after several years there can be a normalization of the levels. We know that aging and comorbidities influence the levels of von Willebrand factor, and there is an increase levels of von Willebrand factor, but also it's important for the clinician to know, to discuss with the patient, that there is no a clear demonstration that increased von Willebrand factor levels in patients with mild deficiency may be associated with the disappearance of bleeding symptoms. This needs to be clarified, and some studies are going to demonstrate that the normalization of von Willebrand factor level are associated with a normalization also of the bleeding phenotype. So, without the minimal factor, von Willebrand factor levels required for safe hemostasis, we don't know, we have no evidence that elderly people have different hemostatic requirements compared to the younger, so we have to treat this patient population in the same way. We know that bleeding symptoms are particularly associated with a reduction of von Willebrand factor levels below the level of 20, but of course there is a heterogeneous pattern also with this. And we know that usually guidelines suggest that von Willebrand factor levels above 50 units per deciliter should be maintained for at least 3 days after surgery. So usually the threshold of 50 units are used to manage people with von Willebrand disease. So what are the most critical bleeds in elderly patients with von Willebrand disease? We have already seen that GI bleeding is particularly critical in elderly people with von Willebrand disease. And we know that gastrointestinal bleeding associated with angiodysplasia is very frequent in the elderly population, because it's a part of degenerative aging process. Is very frequent when we assess by endoscopy the presence of the bowel situation, and is present in 3% of patients, of individuals over 65 years of age. And we know that this rate is even greater if we assess the bleeding cause in this patient population, because the incidence may range from 3 to 6% in endoscopies carried out for bleeding in the elder population. And we know that there is also an association of the risk of GI bleeding and angiodysplasias in patients or individuals having a deficiency of the largest high molecular weight von Willebrand factor multimers, as represented in this panel. And this occurs frequently in normal individuals having aortic valve stenosis. So you see that according to the type of von Willebrand disease, you see that the risk of GI bleeds is very high in patients with type 3 and type 2A von Willebrand disease, because these patients usually lack high molecular weight multimers of von Willebrand factor. On the contrary, you see that the risk of joint bleeding is very high in patients with type 3, because in addition of very low levels of von Willebrand factor, they have also very low levels of factor VIII. What about joint bleedings? There is a clear evidence that joint bleedings are associated with more severe von Willebrand disease types, with MASX, with the use of clotting factor concentrates, and usually there is an under-assessment of the risk of joint bleed and also of a late arthropathy occurring in patients with the von Willebrand disease. You see that a recent study assessed that the pattern, the rates of joint function limitation is very similar in patients with type 3 von Willebrand disease and in patients with moderate hemophilia A, who usually have similar factor A levels in plasma as in patients with von Willebrand disease. There is no important difference of joint bleedings and joint pattern, including joint Rome in patients with von Willebrand disease as in patients with moderate hemophilia A. And you see that, you know that for hemophilia, the approach of prophylaxis has been first explored in Sweden, and also for type 3 von Willebrand disease, you see that prophylaxis have been started some decades ago in Sweden. You see that the population of 35 patients, mostly with type 3 von Willebrand disease, has been treated with the prophylaxis with different schedule of treatment. You see that 17 patients on prophylaxis for arthrosis still maintain 1 to 4 episodes per year, despite the fact that there was usually an improvement of the phenotype of this patient. But you can see that most of these patients developed chronic arthropathy and also clearly by evidence clinical radiologic pattern of changes. And here you can see that usually in pediatric age, the reason for prophylaxis is represented by epistaxis, while you see that over the age of 15, GI bleeding and joint bleeding represent the most frequent cause for undertaking prophylaxis. And a recent study in French showed that the approach of prophylaxis or long-term prophylaxis was able to strongly decrease the risk of bleeding for GI bleeds in patients with type 3 von Willebrand disease, and similarly also for joint bleeds. But you can see that some patients still maintain a very frequent rate of bleeding, of GI bleeding, but also sometimes of joint bleeding, despite the fact that they are on prophylaxis. And an Italian study some years ago also demonstrated that the main reasons for prophylaxis was the presence of joint bleeding and GI bleeding. And you see that most of these patients on prophylaxis were successfully treated by this approach. And you see that the few failures were associated with the presence of GI bleedings. So how to manage prophylaxis in von Willebrand disease? There is a clear evidence that similarly to what happens in hemophilia, prophylaxis should be now started after a single joint bleed occurring in pediatric age. Short-term or even long-term prophylaxis should be considered for recurrent epistaxis associated with anemia. This happens especially in the children population, and so we have to manage accurately with this approach also this population. Prophylaxis is usually recommended after 2 episodes of GI bleedings with anemia occurring after a period of 6 months. Of course, we need to consider the use of instrumental diagnosis and sometimes also of instrumental approach for heal the presence of angiodysplasias and lesions, especially if they are single or very few. Otherwise, it's very difficult to manage without taking into consideration pharmacological approach for GI bleeding. Usually, there is no uniform schedule of treatment. Usually, the suggestion is start with a single once weekly administration, but usually twice weekly is the most frequent approach and most also approach associated with a successful outcome. And we already heard from Katie that perimenses prophylaxis should be also considered for menorrhagia in case of failure for with estrogenic treatment, or if the woman is not willing to take these agents. So in the last part, we will have to discuss what about the present comorbidities, and especially address the risk of cardiovascular events in patients with von Willebrand disease, and possibly measurement for these comorbidities. There is some evidence that the risk of a cardiovascular disease, over cardiovascular disease in patients with von Willebrand disease is lower compared to the general population. You can see that there is a reduced risk of myocardial infarction, a reduced risk of ischemic stroke, and a reduced risk of coronary heart disease. So it seems that in some way, von Willebrand factor deficiency is protective against the risk of cardiovascular disease. But again, we have to stress the point that von Willebrand disease is very heterogeneous, so patients having mild deficiency are the risk similar to what happens in the general population. And you see that among these patients, the prevalence of a risk factor suggests that for patients with arterial events, the common risk factors are higher, more frequently represented compared to patients with von Willebrand disease with no arterial events. You see the smoking, diabetes in the blue bar are associated with a greatest risk of arterial disease in patients with von Willebrand disease. And here, a further study suggested again that the prevalence of cardiovascular disorders is lower in patients with von Willebrand disease compared to the general population. And again, you see that in patients with von Willebrand disease with cardiovascular disorder, you see that the common risk factors are largely represented compared to patients with von Willebrand disease without cardiovascular disease. So again, hypertension, hyperlipidemia, diabetes, obesity, and smoking. So the same approach we have with the general population should be in place also for patients with von Willebrand disease. So recently we published a consensus guidelines for the antithrombotic treatment in patients with hemophilia. We have no such documents for the management in patients with von Willebrand disease, but it looks reasonable to use the same approach, especially for patients with a severe deficiency, and try to manage the requirement for different antiplatelets or anticoagulant requirements in the same way. So try to maintain some significant levels stable into circulation to avoid the risk of bleeding. But again, the most important suggestion is the fact that the prevention programs also for patients with von Willebrand disease are key. The guidelines reported that for patients on prophylaxis, we need to reassess bleeding symptoms over time to still consider the fact that prophylaxis is truly needed or not. And for the management of the cardiovascular event, you see that the main remark is the fact that we should not avoid the use of antiplatelet or anticoagulant treatment in patients because of with von Willebrand disease, because they are affected by von Willebrand disease. So there is no major obstacle to use anticoagulation in patients with von Willebrand disease if indicated. So you see that for patients with von Willebrand disease having an increased bleeding score, we have to consider prophylaxis for the presence of major bleeding, and we need also prophylaxis if the patient is in need for anticoagulant treatment or dual antiplatelet therapy. For patients with a mild deficiency, we have to consider prophylaxis for need of anticoagulant treatment or dual antiplatelet therapy, because these pose the patient at an increased risk of bleeding during this treatment. And for patients with normalized overage type 1 von Willebrand disease, you can see that for some management of some bleeding risk situation, we can use the tranexamic acid and plus or minus they use also desmopressin that is not contraindicated in this setting. So what about the take-home messages? We are seeing that patients with type 1 von Willebrand disease with levels of von Willebrand factor greater than 30 units per deciliter diagnosis, this factor tends to be normalized with age. Patients with the more severe deficiency, type 2 and 3, do not show significant changes with age. The bleeding phenotype over age should guide the need for treatment, so patient maintain still a significant bleeding phenotype should be treated the same way as the younger people. Bleeding risk remains substantially unchanged in severe cases, while little is known of what about the pattern has in the patient with normalization of the levels. Comorbidities may influence these levels and could influence bleeding risk. Prophylaxis required for recurrent bleeding, GI bleeding, especially and joint bleeding, if not already ongoing, and antithrombotic treatment because of cardiovascular events should not be avoided, is considered indicated. Thank you for your attention, and here to take your questions. Thank you.
Thank you very much, Professor Castaman, and also to the other speakers, of course. That's been a very clear and comprehensive presentation and lecture on aging. So now we open the Q&A session.
And
Remembering that, yep, sorry, come there.
Yeah, I just wanted to say that it's for the very first time, I think, that we don't have questions in the chat. I believe it's a very difficult topic. And, oh, okay, we have something.
Plus one.
Yes, but before we switch to the questions, so if you feel more comfortable by just raising your hand and asking out loud, that's also fine for us. So no need specifically to drop them in the chat. So please do ask questions. It's very unique opportunity to have the speakers together today. So please do it. Okay, so we have some questions. Okay, now they're bombarding us with questions.
Was just a matter of time of finishing.
Yeah, so before I start reading the big one, I will probably ask the very last one that we have just received. So what about cancer and VWD? That's the question. I'm not sure what is the exact meaning of this, but I believe Professor Castaman understands.
Okay, I'm not sure I really have correctly understood the question, but there is no association of cancer, the risk of cancer and von Willebrand disease, apart, of course, from those patients who got infected in the past with the hepatitis C virus or hepatitis B virus that are not completely clear, or they maintain some pattern of liver disease that could be at risk of developing, especially liver cancer, but no increased risk of cancer because they are affected with von Willebrand disease as a stain.
Thank you so much. William?
I have requested you to unmute yourself. Are you able?
Oh, yes, I am. Yes, thank you. Yes, I want to thank all the speakers for their insights and contributions. My question is to Professor Castaman and to Kathy as healthcare professionals, what reactions have you received over the years from patients who have been told that they no longer have von Willebrand's disease because they've normalized their factor levels? And what support do people and patients in that position require?
Please, Katie, if you want to start first.
So I have to be honest, where we might slightly buck the trend. We don't tend to declassify von Willebrand's disease with increased levels. We continue to monitor for bleeding symptoms, and as Professor Castaman noted, some people with normalized levels continue to have bleeding symptoms. So we absolutely support the individual and their bleeding symptoms rather than declassifying based on levels.
Yeah, I agree. But the first important thing for a clinician is to rely on the bleeding phenotype, because we have patients who normalize and they do not have any longer any bleeding. We don't see them for at least 20 years, and then they came just because they need a surgery or something like this, so they need to have a statement about what to do during surgery. But some patients, they are not, of course, considering them as completely normal subjects after the first diagnosis of von Willebrand disease. But you know that over years, also laboratory methods has changed. So sometimes now we have a more sensitive, more accurate laboratory tests, and so the diagnosis may be reconsidered, because we have a better capability to correctly track the von Willebrand factor deficiency. And sometimes I want also to discuss with them, and also I'm stressing the fact that sometimes we should try to avoid the stigma of genetic disorders in patients with a very mild deficiency, very small risk of bleeding, that of course, according to the different countries, may have some difficulties, for example, with insurances, or having some discrimination with the job or something like this. So we try to avoid when there is a very minimal bleeding phenotype and the deficiency of von Willebrand factor occur over age. We should try to avoid to burden the individual with the definition of having a genetic bleeding disorder.
If I may add, Daya, and to what has been said, thank you, William, for that question. From a perspective of patient, because there was a recommendation on the latest guidelines, from ISTH, ASH, and WFH, and the American Haemophilia Society for Foundation. I think it needs to be talked. It needs to be, it's a shared decision-making process that it was underlined, because for a patient, it might make sense to have, remove diagnosis, or to have, but sometimes it might be, confusing or lost, or, a misunderstanding, and they don't, they might understand the process of, the rise of the level of von Willebrand, but their life, it might not reflect that also, like it was mentioned before. And so it's a very fine line. It's a process that might take a while, and it's got to be a process that's got to be shared between the health professionals, the patient, and I would say maybe to the extended also family, because also that, von Willebrand is, one thing, but what about my brother, my sister? They still have, and that's also that maybe sometimes might be bring more confusion to the patient and to the entourage. So it's a step-by-step process, and it's a long process. It's not a one shot.
I agree. There is no single statement that is able to encompass all the possible situation we are facing with during our activities. But it's important, of course, first of all, start with the pattern of bleeding the patient may have or may have during the previous years, and to discuss, considering this pattern, what to do with the future. And I agree that, of course, we need time to present on the possibility with the patients and the family. And most of this situation, to be honest, occur for patient having a single demonstration of deficiency, some minor bleeding episodes, and in the family there is no other person with the von Willebrand factor deficiency and the bleeding phenotype. So we have to cover all the situation we could face with during our activity.
Thank you very much. And following the discussion, Baiba brought phenotype is more important than levels, in my opinion. I was always told I'm mild, but I have the lowest factor levels in my family, and also moderate phenotype. And my factor level keeps falling down with every year. I also cannot understand how and why diagnosis should be removed if it is genetic mutation that causes it, even if levels are normal and no treatment required at the moment.
I think that we should avoid any misunderstanding. We are talking about patients with mild deficiency, mild bleeding tendency, and very often without any causative mutation. So this is definitely considered as a risk factor for bleeding, the presence of a low von Willebrand factor, but not von Willebrand disease, because there is no causative mutation for most of this situation. So it variance with what happens with the Baiba, because I see that the levels are very low. They have a phenotype, a moderate phenotype. So maybe I would ask if the mutation has been looked at in her family and of course herself.
Thank you so much. I'm switching to the question from another patient. For a female patient with atypic von Willebrand disease type 2B, who has lived with major bleeding episodes, there is a possibility that with aging, the condition may lead to the new bleeding episodes, such as acute bleeding episodes without medical interventions.
I can say, yeah, absolutely. That so just I think I'm getting this right, that historically no bleeding symptoms, but then as they're aging, concerned about bleeding issues, so spontaneous bleeding issues. And certainly if we think about the angiodysplasia picture, we do see a number of individuals with type 2 von Willebrand's disease who have historically not really had bleeding symptoms, but as they've aged and developed angiodysplasia, they have had significant GI bleeding, which has required lots of intervention from us. So we, in addition to the two ladies I spoke about, we've got another gentleman in his 50s who's again has started prophylaxis with Voncento in the last year because of angiodysplasia. So absolutely, he historically has not had significant issues, has not really had to think about von Willebrand's disease in his life until this point where it really is having a huge impact on him.
Thank you. And so Professor Castaman, Baiba really thanks you. She said, now I understand you are the first to explain that it regards only few patients, not everyone who is getting old and normal, referring to the phenotype discussion before. So, and then I see
so that's a bit tricky because this is a comment. Sorry, Mariangela.
yes, please.
Because I know this patient, a parent actually. So it's from Somalia. The thing is that this question is really for the pediatric hematologist actually. So I don't know if Professor Castaman wants to take this one. So I will read it anyway. And then of course, up to you. So in Somalia, first of all, they are thankful for the opportunity to join our webinars about different bleeding disorders and in this case von Willebrand disease. So the question is that their knowledge and resources are very limited. And in terms of prophylaxis for a child under 5 years old, from what I understand, so we are not allowed. Okay, it's a bit difficult to understand, to be honest. So the child is 15 kilos, and Ahmed gives him every week 750 international units, factor 8, or even every 10 days. Is it the correct number of international units? Is it okay?
Okay, but is she referring to hemophilia or von Willebrand disease? Hemophilia, okay. Of course, you must use what you have in your hands. This is the first approach you can do. This is an important aspect because approximately 75% of hemophilia population in the world are not able to approach the use of prophylaxis as in the Western countries. This is, of course, an important disadvantage that we should try to take further with also the advocacy of the European Haemophilia Consortium, World Federation of Haemophilia, and so on. So the only thing that I can suggest to say that, okay, if you have those concentrates, you must use those concentrates. It depends on the availability you have of the concentrates, first of all. And then if you have a possibility to infuse your baby at least twice a week is a good situation compared to other situations. Of course, it's not the ideal situation, but you have to start it to live with what you have in your hands.
Thank you so much. Do we have any other questions from the audience? Not in the chat, but probably someone wants to ask.
So maybe while waiting if new questions are popping up, I can advertise next webinar that will be on the 16th of January, so on the new year. And it will be on von Willebrand disease in the emergency room. And with us, we will have the Professor Flora Peyvandi from Ospedale Maggiore Policlinico in Milan, and Sandy Maini, a patient advocate. And
I think there are no questions, and some last messages from the speakers if you want to say something to the audience about aging, von Willebrand disease. I understand it's very difficult topic, and I see that also in the chats with von Willebrand committee at the EHC that there are many things that have been told today that they hadn't heard before, and it's very important that we keep educating the community and also the healthcare professionals because it's two-way road for sure. And any last messages from the speakers?
Well, I suppose what I would say is just as a follow-on from Will's question about ensuring that a diagnosis of von Willebrand's disease doesn't impact on somebody's access to the appropriate provision of care. So just because somebody's got a diagnosis of von Willebrand's disease shouldn't prevent them from having screening, shouldn't prevent them from accessing appropriate aging care. So whether that be cardiovascular disease access, whether it be screening. So I think that's a really important thing to take home, that we need to ensure that we're supporting appropriate access to those services.
Thank you so much. Professor Castaman?
Oh, the only thing that I would like to emphasize the fact that there is a gap that now we are trying to fill about the prophylactic approach for patients with von Willebrand disease compared to patients with hemophilia, because we know that it's just a matter of at least 20 years that we are using the prophylaxis, widespread use of prophylaxis for patients with hemophilia, while there is a delay use and under use of prophylaxis for patients with von Willebrand disease, with the risk of having, especially as to the joint bleed, adult patients with severe arthropathy. We are still seeing sometimes patients, let's say, around the age of 30, 35 with type 3 von Willebrand disease and a significant joint arthropathy. So we should very more aggressive in starting prophylaxis at the earlier age, especially in children. We are, of course, trying to find other approaches, other agents that are under study, including emicizumab or non-replacement treatment with other agents to facilitate prophylaxis even in children, because sometimes we know that most of our patients are still using plasma-derived concentrates rather than recombinant agents, similar to what happens is at least 30 years in patients with hemophilia.
Thank you so much. Nicolas?
Yeah, well, a lot of things has been said tonight, and thank you for everything. One thing that I would like to emphasize, it's a message on both sides, on the healthcare professionals and the patient sides. Two things. I think for health professionals who work in the in France, we call them rare bleeding comprehensive care centers. That really, it's another effort to reach out to all patients. Of course, we're talking about von Willebrand disease tonight, but aging, I think it's a process where there's a lot of things going on, and I think could be another way to reach out to those patients that I know that you don't see them that often, like you mentioned. Some of them, for 20 years, and then just they need a surgery or whatever, they just show up and say, oh, I need my a specific regimen or whatever protocol, but it doesn't work like that. So you have to maintain that relationship. So that's one thing. I think aging, it could be a way to reach out. But on the other hand, is like Kathy said, it's like nothing is impossible. It's not because you're concerned with von Willebrand disease that you cannot have access to this, to that, whatever. Because very often that's the message that we hear from like a general practitioner, like a dentist or anything like that in general life, and that's very frustrating for patients. So that's a message that I want to send out to the patient community, is like nothing is impossible. Everything could, even though there's no treatment in your country, there's alternative. There's small treatments sometimes, depending on the type and everything, that could work out, and that could people could benefit. And also for the patients, please reach out to your healthcare professionals, to the comprehensive centers. They're there for that you're never going to be, because so often I say, oh, but I'm going to bother them. I don't feel. No, that's excuse me, but that's your job. That's their job, and that's what they're there for. So please don't hesitate to reach out and to get the proper care that you need for you, whatever it is your situation.
Thank you so much.
Thank you. So we have a very good feedback in the chat. I think it has been very educational, complicated subject, and congratulations for this session. So thank you to the speakers. Okay, so I think we can close the session. We had a very nice discussion. Thank you very much for nourishing so much the Q&A. So, well, thanks again to the speakers for sharing with us all your expertise and for having dedicated us your time. And I hope to see all of you on the 16th of January for talking about the emergency situation when it comes to von Willebrand disease patients. Thank you.
Thank you, Mariangela. Thank you.
Bye-bye.
Thank you. Bye, everybody. Bye-bye.
Thank you. Bye.